All right, well, I'd like to thank you all for coming by and checking out our presentation on how to reduce your risk of ACL injury. We're pretty passionate about reducing risk, and we think that staying healthy is one of the most important things to long-term success when it comes to activity and staying active throughout your years. So thank you for tuning in, and please leave any comments and share your thoughts and ideas and your takeaways because it helps us to get better. So the goal of this presentation is we are going to spend some time learning what is the ACL and how does it function. We'll talk about how the ACL is injured and what the implications are and how you can reduce your risk of injury. My name is Pete Mogan, and I first learned about the importance of injury prevention when I was a football player at the University of Western Ontario. I learned how important it is to stay healthy and how quickly an injury can destroy your progress and destroy your ability to compete. Most recently, I've been working in healthcare for over 10 years. I started my professional career in healthcare as a pharmaceutical rep, working in the areas of cardiovascular, psychiatry, and diabetes. And most recently, I've been fortunate enough to work in orthopedic surgery, starting out as a sales rep in orthopedics, and then most recently progressing into running the medical education program, where my job is to train new sales reps to help them understand surgeries and how to support the surgeons, and also to train surgeons on new techniques. This job has given me a whole lot of insight and a whole lot of help in understanding anatomy, injuries, and all the things that we can do to work to prevent the injuries. So this is how I spend a lot of my time in the ORs. This is actually a picture of a ACL surgery, and we can see the surgeons operating, and it gives me an opportunity to see what the surgeons are doing and also a lot of opportunity to ask some great questions. Now, over the years, I've seen a lot of these pictures, and unfortunately I've seen a lot more of the picture on the right than the picture on the left. On the left, you have what surgeons will see during an arthroscopic procedure, and we can see a nice healthy ACL. On the picture on the right is what a torn ACL looks like. I live in London, Ontario, and I've been fortunate enough to work with some of the great surgeons here in London. On the upper left, we see a picture of a university hospital where most of the sports surgeons in London, Ontario work. And in the bottom right is a picture of Victoria Hospital, and that's where pediatric orthopedic surgery will happen. And unfortunately, we're seeing more and more pediatric orthopedic surgery requirements, partially due to sports specialization and so many children playing sports and specializing at such a young age. We're seeing more and more repetitive stress injuries and higher levels of competitions, which are exposing kids to more and more potential for injury. Yet another reason that injury prevention is so important. Now we're going to move along and take a look at some of the relative knee anatomy. So here we see a very basic diagram of a knee. On the top you see the femur, or what's commonly known as the thigh bone, and lower we see the leg bone or the tibia, and in the middle is the knee joints. In the front we see the kneecap or the patella, and we have labeled on this diagram a couple of key supporting ligaments. We see the anterior cruciate ligament, which is what we're going to be speaking a lot about. Right in behind it is the posterior cruciate ligament. On the right side of the diagram, you see the medial collateral ligament, which runs on the inside of the knee or the medial side of the knee. And opposite to that is the lateral collateral ligament, which runs on the outside of the knee. We also see two very important structures known as the menisci. We see the lateral meniscus, and just opposite to it is the medial meniscus. And we'll talk about the importance of these structures a little bit later on. The knee is a very complicated joint capable of lots and lots of different types of motion. Most people understand the flexion-extension motion that the knee makes, as this is the most common, but the knee also produces varus and valgus motion. We can see valgus is when the knee collapses inwards towards the midline, and varus is when the knee collapses or extends outward. Somebody who is bow-legged would be referred to as varus, and somebody who's knock-kneed would be referred to as valgus. In addition to those four movements, We also see that the knee slides anterior and posterior, as well as the knee rotates, with the tibia rotating relative to the femur. So what is the ACL? The ACL is a structural ligament inside of the knee, and its primary function is to resist anterior tibial translation. What that means is that resists the tibia from sliding forward relative to the femur. Now, in most situations, in athletic situations, the foot is actually planted into the ground and fixed. So what the ACL actually prevents in this situation is the femur sliding backwards off the tibia. You can see the schematic diagram there on the left showing the ACL running from anterior, or the front of the tibia, to posterior, or the back of the femur. In the image on the right is a cadaveric specimen where the femur has been sectioned in half, and we can see the attachment site of the ACL on the femur, that's the bone on the top, and how it runs down to and connects into the front of the top of the tibia on the bottom. So not only does the ACL work in resisting anterior tibial translation, or having the tibia slide forward relative to the femur, it also has a significant role in controlling rotation. And this is where we find that the ACL injury happens most often, is in a position of flexion with rotation. There is a strong rotational component to ACL injuries. Some other key structures that exist in the knee. We talked briefly the PCL, or posterior cruciate ligament. This runs in the back of the knee and attaches on the back of the posterior aspect of the tibia, as we see in the picture on the bottom on the left, and runs towards the front of the femur, and it acts in direct opposite direction from the ACL. It resists the tibia from sliding backwards relative to the femur, or in the situation where the foot is planted and the tibia is fixed, resists the femur sliding forward relative to the tibia. The other two important ligaments that we see here in this diagram on the right are the collateral ligaments. We have the lateral collateral ligament, which is on the left side of the picture that you're looking at, and it connects the femur actually to the fibula. What it does is it will resist from patients going into varus, or bow-legged. On the inside of the knee is the medial collateral ligament on the right side of the image that you're looking at. And what it does is it resists valgus force, or the knees collapsing in, somebody in a knock-kneed position. Another key stabilizer that we touched on earlier is the meniscus. The meniscus has two functions. If we look at the image on the left, we can see how the meniscus works to stabilize the femur. The distal femur is very round, and the proximal, or top of the tibia, is very flat. And so when these two come together, there's not a natural inherent bony stability. So the meniscus acts to cup and accept the round distal femur and keeps the femur sitting properly on the top of the tibia. If we look at the image on the right, the second very important function of the meniscus is to offload forces. Every time we step, or we jump, or we run, the femur wants to smash into the top of the tibia, and the meniscus works to cushion a lot of this force. And we can see in the image on the right, as the femur comes down, the meniscus works to accept and dissipate a significant amount of this force. If we look at the role that the meniscus plays, the lateral meniscus dissipates or absorbs 70% of the force that flows through the lateral side of the knee, and the medial meniscus dissipates or absorbs 50% of the force that goes through the medial side of the knee. This works to protect the cartilage. So how is the ACL injured? The ACL is most commonly injured in a non-contact twisting injury. We see in this picture, the young lady has planted her left foot and is moving to the right, but because of great shoe technology and good turf integration, her foot is firmly fixed into the ground, and as her body continues along, the weak link now becomes the ACL structure. And as this progresses, you can see how she begins to stress the ACL to such a point that it reaches the point of rupture. If you're watching sports and you see an athlete in the middle of a field with no one around them, and all of a sudden they collapse on the ground, there's a high likelihood that they have torn their ACL. So who is at risk for an ACL tear? Primarily, it's athletes playing in cutting, pivoting, and single leg landing sports. About 70% of ACL injuries are non-contact injuries that involve sudden deceleration. Another prime candidate for ACL are females. Females are 4 to 6 times at a higher risk than males, and we'll discuss the reasons for this in a few slides. The other major risk factor is a previous torn ACL. For patients who have already torn an ACL and undergone repair, the risk of re-injury is about 15 to 20% higher than baseline ACL injury risk, so it is a significant concern. There are many risk factors for ACL tear, and they can be categorized as either modifiable or non-modifiable. We'll take a look at the non-modifiable risk factors first. The first non-modifiable risk factors are your basic anatomy. First thing we're going to talk about is the Q angle, and this is one of the contributing factors as to why women have a greater risk of ACL tear than men. On the left, we have a picture of a female pelvis, and on the right, a male. And you can see that as the female develops and their hips widen out, the angle with which their femur approaches their knee increases. Keeping in mind that the ACL runs from the inside to the outside, or the medial to the lateral side, as the lateral femur moves further and further away from the medial tibia, this begins to stress the ACL. Patients who have a naturally wider pelvis will have a greater Q angle. The anatomical structure in the knee where the ACL is located is referred to as the notch. In patients who have a narrow notch, the risk of impingement, of bony impingement on the ACL is significantly greater. The last non-modifiable risk factor is generalized ligamentous laxity. These people are commonly known as double jointed. This is assessed through a score known as the Baton score. The Baton score looks at your ability to take your thumb to your wrist, your ability to bend your small finger past 90 degrees, hyperextension of your elbows, hyperextension of your knees, and your ability to put your hands flat on the floor. If you're able to do 7 out of those 9 things, you would be considered generalized ligamentously lax. This means that your connective tissue is slightly more loose than is what is typical. And as a result, you often have significantly greater flexibility than most people. Other factors that can contribute to your risk of ACL injury are your age, genetics, hormonal variation, as there has been some relationship between female hormonal cycles and the risk of ACL injury, and as stated earlier, previous injury will contribute to your risk. Environmental factors that play a role are the playing surface. More recent years, synthetic turf has been implicated in more and more ACL injuries due to the interaction between footwear and the ground. Weather, rain can cause, and snow can cause a more slippery surface. And equipment, increasing your shoes gripping, or for example, putting in longer studs into turf cleats can increase the grip so much so that the weak link during a pivoting movement now becomes the ACL. In terms of modifiable risk factors, these are the ones, or biomechanical risk factors, that we have a lot of ability to impact. Muscle strength and muscle balance. Specifically looking at the knee, many people, especially females, are referred to as very quad dominant, and so balancing that out by strengthening the hamstrings can significantly reduce your risk. Proprioception training. Proprioception is your body's awareness of its place in space, and this can help improve your coordination, your balance, and protect your knee. Lateral trunk displacement. As athletes get tired and fatigued during the game, the relationship between their body and their hips changes, and as a result, we see movements and significant more stress as fatigue sets in on the knees. Knee and hip flexion angles, teaching athletes to cushion blows and accept more with greater flexion in their hips and knees can work to protect the ligamentous structures and transmit more force to the tendinous and muscular structures of the body. Ankle stability and mobility. Many people have very poor dorsiflexion or ability to flex their ankle, and this transmits increased force to the knee. Knee abduction and adduction moment. This has to do with when you're in a gait or a stance phase, if your knee collapses in or bows back out. Hip and tibia rotation. This has a lot to do with the strengthening of the external rotators of the hip. Foot pronation. This can be corrected by releasing tight structures that are putting the foot in this position and strengthening the muscles that allow for foot neutrality or foot supination. Hamstring flexibility. Tight hamstrings can predispose your risk to ACL injury. Neuromuscular control, your ability to control your muscles to produce a very coordinated and safe movement pattern, and this can be trained. And core strength and endurance, your ability to maintain proper relationship between your upper and lower body, ensuring that force is transmitted through the more safe way possible. The rates of injury are actually quite high. In soccer, the rate of ACL injury is more than twice as high in female players than it is in male players, and it's young adolescent females who are at the greatest risks. Looking at research studies, females were twice as likely to sustain an ACL injury playing soccer than in any other sport. And females are 4 times more likely to sustain an ACL injury playing either soccer or basketball compared with volleyball or softball. We see this reflected in the rates of ACL injuries amongst high school athletes. And you can see that in high school, female soccer is the #1 sport for ACL injury. This is closely followed by male football, American rules football. And you can see the other sports continue to have increased rates of ACL injury. And this is another reason to ensure that children are coached properly in terms of how to move and all the things that can be done to prevent this injury. We see that tears in school-age children are definitely on the rise, with more and more kids happening between the ages of 14 and 18. This is in high school when kids are super active, competing in multiple sports with multiple distractions in their life, and often left to coaches who are not as well trained or understood in the best ways to prevent these catastrophic injuries from happening. One of the big challenges with ACL is at the time of the injury, there is significant damage that occurs. The image on the left shows an MR scan of a patient who suffered an ACL injury, and we can see the arrows pointing to very white, bright spots. On an MR scan, white indicates fluid, and fluid indicates damage or inflammation. And these two bone bruise patterns are very characteristic of an ACL injury. On the image on the right, we see how this bone bruise occurs. During the time of injury, the lateral or outside edge of the femur will actually slip off the tibia. And when it goes to reduce or come back onto the tibia, the distal or end of the femur smashes in to the back of the tibia with significant force. This causes significant damage to the underlying bone. And this damage is partially thought to be a contributing factor to the onset of osteoarthritis that is seen in many patients after suffering an ACL injury. One of the major concerns with regards to ACL injury is that often progressive damage can occur. When considering how best to treat a patient, the first consideration is alignment, and this looks at the bony structures. And when patients are malaligned or their alignment is off, this is where force is loaded onto structures that weren't intended to accept them, and this is where a lot of problem comes from. The second issue becomes stability. This ensures that a stable joint accepts force properly and dissipates it around all the supporting structures. And all this is done in an effort to protect the cartilage. The cartilage which coats the end of the bones and allows for smooth, pain-free motion, and it's the damage of the cartilage that leads to a lot of significant pain and incapacity as we age. When considering the important things to maintain in a patient, it's important to understand that if anything in the decision tree above is damaged, everything below is at risk. So if a patient's alignment is off, there's a good chance that all the structures providing stability will be damaged eventually. And once that is all damaged, there's a very high risk that the cartilage will suffer significant damage. So what happens when you tear your ACL? Well, the ACL contributes significant stability to the knee, and so loss of the ACL leads to a loss of stability. This requires the other stability structures of the knee to take on significantly more force. One of the structures that's very susceptible to damage with this increased force is the meniscus. Once the meniscus becomes damaged, this further decreases knee stability, and this becomes a vicious circle. It leads to more damage. Also importantly, if you remember, one of the other structures of the meniscus was the shock absorbing feature and offloading or protecting the cartilage. As the meniscus is damaged, you see a progressive loss of this ability to lose force, and as a result, more and more force is transmitted to the cartilage. This meniscal damage significantly increases the patient's risk for osteoarthritis. Let's take a look at what exactly arthritis is. Arthritis is very common, but unfortunately poorly understood. That is part, in fact, due to the fact that there are many different types of arthritis. Arthritis is one of the leading causes of disability in North America, and common symptoms of arthritis are pain, stiffness, and loss of range of motion. If you look at the images down below, the image on the left shows a healthy knee joint, and you can see the blue arrows are highlighting the joint space or the clear space between the femur and the tibia. This is because cartilage does not show up on x-ray, and even though the cartilage is in contact, it looks as though the bones are not in contact. In the image on the right, we can see the bones are definitely in contact, and this is because there is no more cartilage left in this knee. And this is bone on bone, or this would be very painful osteoarthritis. Arthritis is a degenerative disease, and one of the most common forms of arthritis is osteoarthritis, or commonly known as OA. In osteoarthritis, cartilage wears away from the bones. This causes the bones to rub and causes significant pain. Some common risk factors for developing osteoarthritis are excessive weight, family history, age, and a common one is previous ACL injury. And this comes from the list of risks for developing arthritis found on the Arthritis Foundation website. So arthritis is the degeneration of cartilage. Cartilage is a very specialized structure within the body. We have many types of cartilage. Cartilage makes up our ears and our nose, but the type of cartilage we're talking about today is very specific and is called articular cartilage. It is very resilient and smooth elastic tissue. Type 2 articular cartilage is highly organized and is designed to resist both shear and compressive forces. We can see the image on the right, the top layer of cartilage, the collagen fibers are lined up parallel to the joint surface, which resist shear force. There's a transition zone in the middle, and in the bottom zone, the collagen fibers are lined up perpendicular to the joint surface, which resist compressive force. One of the major challenges with cartilage is it has very poor blood supply, and as a result, has very poor healing capacity. When it comes to treatment for osteoarthritis, there is no good treatment, primarily symptom relief. The only definitive treatment for the pain of osteoarthritis is a total joint replacement. And in the image on the right, what we see is the degenerative knee before, and then we see a total joint replacement afterwards. In a total joint replacement, surgeons will cut off or resect the distal or bottom part of the femur, as well as the proximal or top part of the tibia. The femur will often receive a metal implant, and the tibia will often receive a plastic implant. This now becomes the joint surface, is metal on plastic. One of the major challenges with early joint replacement is the earlier that the joint is replaced, the less chance it has for long-term success. If we look at this curve right here, we see the purple line shows the survivorship, or how long joints last in patients who receive them prior to the age of 55. And if we look out to 10 years, almost 12% of the joints put in patients under the age of 55 has had to be revised. Now, when a surgeon revises a total joint, typically it involves removing the original prosthesis, re-preparing the bones, and putting in a new prosthesis. And every time a total joint is revived, the surgeons take more and more bone. And unfortunately, there's a limit to the amount of bone that can be taken. This is one of the reasons that surgeons want to delay putting a total joint into patients until they're much older. Activity level drops off and demand on that implant significantly decreases. This helps contribute to much longer survivorships. And if we see the black line at the bottom, at 10 years, less than 2% of those joints have had to be revised when they're placed into patients 80 years of age or older. Let's now take a look at surgical treatment for an ACL tear. In an ACL reconstruction, surgeons will drill holes in both the femur and the tibia. This will give a place to accept a graft. The most common graft that is used to repair ACLs is what's called a soft tissue or a hamstring graft, where surgeons will take the tendon from the semitendinosus as well as the gracilis and reconstruct the ACL with this graft. Other common grafts that are used are bone tendon bone grafts, which often take a little bone block off the distal or bottom of the patella and a bone block off the tibial tubercle or partway down the shin. And the tendon that you can actually palpate on yourself is used to reconstruct the ACL. Another graft that is used is the quads tendon, and this will take a piece of tendon from the quadricep coming from the patella or the kneecap up towards the hip. Regardless of the graft choice uses, it is significant time for this graft to heal and for the patient to regain range of motion and strength. And the recommendation for return to sport is 12 months. This can have a significant impact on a player's ability to compete after being absent from competition for 12 months as they rehab their surgery. This is another reason why prevention is so important. There are many challenges when it comes to surgery. One of the big challenges is getting access to surgery. Oftentimes, there's significant delay before a patient is able to see an orthopedic surgeon and have their ACL reconstructed. There's also the risk of morbidity of the graft donor site. Most patients will complain of pain from the harvest of the hamstrings or pain from the harvest of the bone block on the tibia. This can lead to long-term and lifelong pain. Of course, there's always the risk of surgery. And remember that the safest surgery is always no surgery. And this is one of the reasons many physicians will suggest non-operative treatment as an initial strategy to address many injuries. Once surgery has been performed, there's now the very important phase of recovery. And even with intense rehabilitation, a reconstructed knee is not even going to be the same as a normal knee, even up to 1 year after surgery. Coming back from surgery too early, it significantly increases the risk of re-rupture and further damage. In many research studies, only 60 to 70% of the athletes are able to return to play, and even those who do return to play are at a decreased level of performance. Looking at a study done in the NFL on players who had returned from ACL surgery, 20% of the players never did return to play, and those who did return to play, there was a noticeable drop in performance. In athletes who have had reconstructive ACL surgery, they often retire from sport at a much earlier age. This impact is even more pronounced in female athletes. And unfortunately, as good as surgical and rehabilitation protocols have become over the years, they have done very little to delay the onset and the eventual progression into osteoarthritis. Return to sport is one of the major considerations for patients who are undergoing ACL surgery. One study looked at the prevalence of return to sport, and at 12 months, only 33% of those patients had returned to sports, and at 39 months, the rate was slightly higher at 46%. But more than half of those who did not return to the pre-injury level of sports participation indicated that it was because of the function of their operated knee. There can be many other factors, such as lifestyle changes and occupational demands, which can play a significant role in a patient's decision to return to sport. This, combined with the experience of surgery and the recovery, can significantly influence patients as to whether or not they're willing to expose themselves to that same risk again. There are many reasons why doing everything possible to prevent an injury is so important, as the cure is never quite as good as prevention. One of the many ways to protect your knee are through neuromuscular training, which is shown on the left, ensuring that the athlete in a position of knee flexion, their knees are tracking over top of their toes. And we see the image on the right, developing good and balanced strength in the quadriceps and the hamstrings to help support the knee during activities. This all leads to proper alignment. If we see the image on the left, as force continues to be imparted through the weight of the body coming down, you can see how the knee will want to collapse inwards. Contrast this to the image on the right, and now there is a very strong, stable base of support with all the joints and the bones stacked on top of each other, smoothly and efficiently transmitting force into the ground. Looking at the second criteria, stability, we look at there's two types of stabilizers when it comes to stabilizing a joint, and when they can be classed as dynamic, which are stabilizers that control the joint throughout the range of motion, often known as muscles and tendons, and then static stabilizers, which provide end range of motion. These are ligaments, bones, and cartilage can be considered a static stabilizer. Strong dynamic stabilizers will provide joint stability as the knee goes through a significant range of motion. Dynamic stabilizers are under control of the nervous system and can be very well trained. The goals of any training program is to improve alignment through neuromuscular training and strengthen the supporting dynamic stabilizers of the joint. There are many recognized prevention protocols specifically designed to reduce risk of ACL injury. The PEP program from the Santa Monica Sports Medicine Research Foundation is the program that we will be looking at shortly. There's a big question. Are any of these programs effective? Well, there's been many research studies to look at exactly this question. Looking specifically at a study which involved NCAA Division I female soccer athletes, they found that when they employed the PEP program, the rate of ACL injuries went down 83% for teams using the PEP program compared to teams that did not. In the second year, the reduction in ACL injuries was 72%. Athletes who had a history of previous ACL injury suffered an ACL injury rate almost 5 times less than athletes not participating in the exercise program. The ACL injury rate for athletes without a history of prior ACL injury was approximately half of PEP program participants. And none of the female soccer players participating in the PEP program suffered an ACL injury during the second half of the season versus 5 who suffered injuries who were not performing the PEP program. This suggests that the benefit of the program is cumulative, and it is recommended that this become a regular part of any team's practice schedule. Reduction in ACL injuries later in the season suggests that training had a cumulative benefit effect. In fact, studies authors suggest that the results may actually underestimate the program's potential because not all programs were as adherent to the program as a recommendation. Looking at the research, the recommendation is that these exercises be performed 3 times per week for maximum benefit. Now let's take a deeper look at the PEP program. The PEP program was developed by researchers at the Santa Monica Sports Medicine Research Foundation. The PEP program contains 5 distinct and significant stages. The first stage is activation, and this is where athletes will perform a series of exercises to help prepare the muscle and the nervous system for exercise. The second phase is strengthening. Specific exercises are focused on strengthening both the quadriceps and hamstring muscles that work to support the knee joint. Plyometrics are training to use the body's muscles in an explosive manner to produce sports-specific movements. Agilities are training the muscles to absorb and reproduce force to change direction, as is often seen with athletic competition. The final component of the program is stretching, and these exercises are designed to release and lengthen key supporting structures. This is increasing range of motion about the joints. Stretching is recommended to occur after the athletic competition. Remember that stretching imparts a relaxing stimulus or a relaxing signal to the muscles, and stretching prior to competition can actually cause a decrease in performance. Prior to competition, you want to perform a progressive, dynamic activation period which prepares the muscles, and after competition, perform the stretching to lengthen and relax the muscles. As part of this program, we have included and developed an ACL injury risk reduction manual. In this manual, you will find much of the anatomy and biomechanical information that is covered in this presentation, along with a complete description of the PEP program and complete exercise descriptions, along with coaching points and pictures of each exercise. To get your copy of the manual, just click on the link in the description and you will receive a link to download the e-copy of this manual. Thank you for watching this presentation, and we look forward to your comments and feedback. And if anyone would like to have this presentation conducted to a group or specific for your organization, please connect with us on either our website or on our Facebook page, and we'd be happy to come and talk and interact with your group. Thank you.